here in Adventist Healthcare, there is a system of hospitals. So the primary hospital is about 25 minutes northwest. I am in the most recently constructed hospital, White Oak, which is kind of just east of Silver Spring, Maryland, which is maybe 15 minutes north of Washington, D.C. And then there is another hospital about 30 minutes south of DC called Fort Washington. We all rotate through all those hospitals, but I am primarily here at White Oak. I am the chairman of radiology here, so I am in charge of all radiology services. So that is both diagnostic radiology and interventional radiology. So diagnostic radiology is what we all know radiologists to do, which is interpreting imaging. So that would consist of ultrasound, X-ray, MRI, nuclear medicine, CT, and using our facilities here, including here, I'm at my desk, and you can see, I'll show you. This is my setup, so it's a 4-screen monitor, 1, 2, 3, 4. So I would use that monitor system here to interpret studies from patients. This is my office, so I have my own system, but we have a reading room next door where there are 4 rooms, and each room has a sliding door and a desk like this one, and you can control the lights and you can interpret your images individually in that room. So that's a little bit of giving you a quick overview of what diagnostic radiology would be. And then you have interventional radiology. So interventional radiology is a subspecialty of radiology where you are doing procedures on patients. So you actually are a consult service. So doctors will call you to help them in the management and treatment of patients. You would bring that patient to you in interventional radiology most of the time, although sometimes we go to the floor or the ICU and we may do procedures at the bedside. You perform those procedures in your interventional radiology area, and then once the procedure is finished, that patient goes back to the floor or back to the ICU, wherever they came from, so that their primary team can take care of them again. So I am a little interesting, I say that in quotes, in that I'm kind of jack of all trades. So my training is in neuroradiology. So neuroradiology is a subspecialty of radiology where I trained an additional 2 years of fellowship after residency at Stanford University. And I trained in the diagnosis and treatment of diseases and ailments of the brain and spine, central nervous system. I also read almost everything. So general radiology, abdominal imaging, chest imaging, X-ray, ER imaging, nuclear medicine. I read all of that. My weak point is musculoskeletal imaging. And that's because musculoskeletal imaging is another subspecialty where those guys read a lot of joints. So elbows, fingers, knees, shoulders. And because it is also a subspecialty like neuro, I tended not to really get too much experience in that after residency. So I kind of, after a while, I was like, I don't know where the shoulder is on the body anyway. So I kind of just left that alone. Excuse me. And lastly, I do interventional radiology. So interventional radiology, as I stated, would be procedures such as, like today, we had a patient who had an intra-abdominal abscess after having diverticulosis that turned to diverticulitis, and an abscess formed. And the surgeon called me to ask me whether or not I could drain the abscess. So we use imaging to place a needle into the abdomen. And through a series of exchanges of wires and catheters, the patient ends up with a tube or a drain coming out of their abdomen that we place into a bag. And so we're draining out pus. It's easy to stick needles in people, but the hard part is not to hit important structures, right? So your main focus is to get the catheter in without hitting the bowel, without hitting the kidney, the liver, or the spleen, depending on what side you're in, and of course, major blood vessels. Similarly, in interventional, we are also the people that we do a lot of what's called embolization work. So if somebody's bleeding, a lot of times the surgeons may say, you know what, we're not going to take them to the operating room because it may be too big of a procedure opening them. So what we do is we may enter their artery through their groin. We go up into the blood vessel in the aorta and we find the exit that may be feeding where the person is bleeding from. And we do like a reverse Roto-Rooter. So we inject embolization material, which comes in the form of either literally coils that look like microscopic snakes, or particles that look like microscopic golf balls, or glue that looks like Elmer's glue, or gel foam, which is kind of like gel foam is kind of like if you were to take like, here's one of my protective masks, and you see this spongy material here that goes on your forehead like that, right? Gel foam is kind of like if I took this, cut it up into little pieces, make a little slurry, and then I inject that slurry, and the slurry then occludes everything it touches vascular-wise. Anything that's bleeding, we can try to embolize. And you know, it's hard to give you an interventional radiology lecture because it's so all-encompassing. But you asked about a day, so my day would be anything, including all of the aforementioned studies and procedures that may come up during the day from the emergency room, the ICU, or from the floor.